Just wanted to jump in and say good afternoon, everyone. I'm Craig Stallings from Rosecrans, just here to kind of provide some more support for Erica.
Oh, aren't you good? Are we that tough?
I guess we'll find out, won't we?
Great to see you.
No, nice to see you, Craig.
So,
Okay, it's 2:00, so I am going to call the September 1st Winnebago County Mental Health Board meeting to order. And I'll start with the roll call. Mary Ann Abadi, present. Richard Kunert.
Present.
Dr. Edward Copeland. Danielle Angelari.
Present.
Dr. Bill Gorski.
Present.
Dr. Terry Giardini.
Present.
Kim Neighbors.
Here.
And Linda Sandquist.
Here.
And also welcoming Craig and Erica for public comment. And we have our advisory members, Wendy Larson Bennett
Present.
and Jay Ware. Okay. Next is our public comment. So we'll go ahead. Erica, you have 3 minutes. And it's
Okay,
your time.
so my name is Erica Gilmore, and I'm the director of our mental health crisis services for Rosecrans. And I wanted to share a little bit about what these grant dollars are doing for our community crisis services and how we're expanding. So one of the exciting things is our enhancement of our medical piece at our Mulberry Crisis Center. So we're working to add 24/7 nursing. And so we're doing a lot of interviews. We just onboarded our new nurse manager. His name is Leonard Voss, and I'm excited about him because he has so much experience. He was married to somebody in the military, so he's had the opportunity to be able to go around and get experience. He was a director at another inpatient crisis mental health center, and he's just worked kind of all over the country. So he brings a great wealth of knowledge to the team. And so we're working on some interviews to get some more nurses in the Mulberry Center. The other thing that I'm excited about is the expansion of our CCRT program. So with this grant, we've been able to add some positions, and we have 3 of those open positions filled, and we're working on onboarding 2 other candidates for a second shift. And this is really exciting because it gives us the opportunity to be able to address mental health in a lot of different ways. CCRT has really shown us that mental health is present in a lot of the 911 calls. Almost all of them probably have some degree of mental health involved in it. And so we're trying to meet the needs in a lot of different capacities. So an example would be like this morning, all of our officers from CCRT were attending a court hearing for a client to try and advocate for his follow-up and get medications and make sure that he's continuing to engage in treatment. And because of that, they couldn't go on a live call for one of our established Rosecrans clients. And so our team lead, Victoria, was able to work with the people that were going, the officers that were going on that live call, and meet them at the Mulberry Center so that we could have that smooth transition and provide the client care. And we admitted him over to our inpatient program today. So it's really exciting. And I'm happy to answer any questions if there's anything.
Generally, the format is that we don't have question and answer at this time, but we do very much appreciate your information. It all is really working in the direction that I know the Mental Health Board has, you share our goals, I should say.
Good.
So hopefully you'll continue down this path, and we appreciate you.
Well, we are very excited and
updating.
hopeful. Thank you for allowing me to be here.
You're more than welcome.
Thank you.
Thanks. Am I done now? Can I go?
You are. You did a great job, Craig. She
Thank
did
you.
a great job. So.
Yeah,
thank you, everyone.
Thank you.
thanks for the feedback.
Yes. Okay. I did have a whole bunch of questions. That's how I felt after, she started giving me this report, because I know a lot of questions. I personally, because I've worked in all the capacities, have that I would have asked her, but this isn't the time or place. It would have gone on for the whole meeting, I'm afraid. But I think that Jason, wherever Jason is, I didn't welcome him because I did not see him. Jason, are you there?
I'm here. I'm not sure where you're at on my,
Good.
where I'm at on your computer, but I see.
Oh, yeah, that's right. You spoke and introduced Erica. I'm sorry. But I do think that it does bring up one, kind of thought I had. And, in terms of these programs giving us updates, Rosecrans seems to really want to do that. They've done it now twice. Is this something that you're going to be doing at the networking more than at the board level, that they would give us updates?
Well, the updates, the entire report outcomes reporting format that we have that's due on a quarterly basis has both qualitative and quantitative updates. So that's really that's the primary feedback mechanism is for those quarterly reports to be completed, and then we will summarize key findings into a report for the board.
Yeah. Okay.
But
Well,
Jason, I really appreciate the face, and the personal take on how the mental health dollars are working in the organization. So it sort of humanizes what we're trying to do. So I personally would not mind hearing from various grant recipients through the year.
I agree with that.
One more thing, instead of just making it putting it in a public comment section, we could make it a presentation, just like when we go present before the county board, and
And we could assign a different organization every meeting to give us kind of an overview on, I mean, I understand where Jason's coming from. We'll eventually get that information quarterly, but I also do have that good feeling about the personal contact, that these agencies are really kind of on top of their game before the quarter ends. They're able to give us a report as to, how many people did you hire? I don't know, something about this is kind of reassuring from my perspective.
Well, and Tim, when an organization, let's say, does a presentation to the county board, then the board members can ask questions, correct?
Correct.
So I like that concept, maybe give it a time limit so that we're not spending 2 hours,
Well, I was going to say we'd have to limit that agenda to 10 minutes.
Yeah, or something. But I think it gives some life to what we're doing. So
Yeah, I agree completely. Jason, how many total funded? I forget the total number now.
15 programs.
So I would think, I really like the idea of the in-face. It's so much more meaningful, the opportunity to ask a question. Will give us an example of what you just said you did. How does it really impact an individual, for instance? But you'd almost, in some respects, it would seem, need to offer that to all of those funded. They may not all, I don't know that we would make that a requirement, would we necessarily? But I think we'd want to offer it to all. And then figure out, is that over the course of a year? And then I think to Wendy's point, is it 5 minutes? Is it 10? And now I'm thinking of the logistics of the timing of per board meeting. Is it 1 or 2, it limited to 10 minutes each? But I think that's a great idea. I'd love to hear from them personally.
Because we'd have to really be more concerned about limiting ourselves in terms of questions.
How true.
So what do you think of that, Jason?
I think to Dr. Gorski's point, it probably would be best as an optional
I agree with that.
exercise for this particular funding year, only because it wasn't dictated as a requirement within
Exactly.
Funding agreements as the other reporting mechanisms were, but to have that as a standing agenda item and to offer that opportunity, if the board finds that beneficial, I'm happy to facilitate that.
I think that's awesome. I think that's great.
Yeah.
especially through the year as things evolve, as they start actually doing the work. So.
Mhm.
Is there any feelings in the other direction that it's not necessary? I mean, I'd like to make sure that this is what the board, really wants. Okay,
I feel we ought to try it and see how it goes. Because we do have these other meetings that Jason's meeting with the people as a system. So we don't really want to duplicate
absolutely.
work or our work, but at the same time, I totally agree that seeing the human faces from these agencies and having us in turn
Mhm.
be more than just simply something on paper, I think is important.
Good point. Okay, so I think that's the direction we want to go, is to offer this opportunity to the organizations that would like to pick up on that.
We
So,
will add that to the next month's meeting agenda and communicate that to programs to see who's most immediately interested.
yeah, because I think if we don't offer it to the others, we're going to have Rosecrans at every meeting. I just think it's their way of communicating with us, which is not all bad. So, okay, moving on to our action items. First of all, I'm going to need a motion for the August meeting minutes. Tim?
So moved.
Tim moved. I saw first. Linda second.
I'll make a,
Okay. So with both motions in place, all those in favor of approving the minutes for the August meeting, please. Oh, we have to do roll call. Mary Ann Abadi, aye. Yes, affirm. Richard
Yes.
Cunard,
Yes.
Dr. Copeland, Danielle Angeliri.
Yeah.
You wrote them. Dr. Bill Gorski,
Yes.
Dr. Giardini,
Yes.
Tim Neighbors,
Yes.
and Linda Sandquist.
yes.
Okay. The next and last action item is our officer nominating of officers. Hang on one second. At this time, I'm going to call for nominations of the president.
That Mary Ann Abadi be nominated for president.
And to clarify the dates, it's for the term of 10/1/2021 to 6/30 of 2022. Are there any other nominations for president? Okay, moving on, the role of vice president. I would like to open the floor for nominations for the vice president for the term of 10/1/21 to 6/30/22.
I'd like to nominate Dick.
Yeah,
same.
So Terry Giardini has nominated Richard Cunard. Okay. Is there any other nomination for the role of president? Hearing none. I've opened the floor for the nomination of treasurer for the term of 10/1/2021 to 6/30/2022.
I nominate Dr. K. Edward Copeland.
Okay, thank you, Tim. Any other?
Second.
Okay, any other nominations for the role of treasurer? Okay, I would like to open the floor for nomination of secretary for the term of 10/1/2021 to 6/30/2022.
There's somebody there named Danielle Angelari. I'll nominate her.
I second it.
Okay. All right. So that concludes the nominations as I understand, and seeing no further nominations. I need a motion to appoint the following individuals. First of all, I think we have to do this per role. So I have to do the roll call for each officer. And at this time, I need a motion to appoint a Mariana Body for the term of 10/1/2021 to 6/30/2022 as president.
So moved.
Second,
Okay, at this time, if there are no further nominations, I will call for a vote. All those in, oh no, roll call. Oh, it gets very tongue twisting here.
Marianne, is it possible for somebody to make a motion that we accept this as a full slate? Or I'm wondering if Jason would know.
Well, he does know, I think.
I think that would be appropriate, to have a motion that appoints all four. since
That
there's-
would save a lot
since
of,
there were no
Okay,
additional
so I'm
nominations.
gonna move then, since, and maybe Danielle can put this in the minutes. I'm gonna move that since all of the positions are, have been nominated and there are no contested elections, that we accept the nominations as a full slate.
I second.
Tim seconded that.
thank you for that.
That was good.
Well, let me really thank her for that.
Yeah.
Going through this, I'm trying to use the correct language. And so at this time, the role, Mariana Body, Dick Kunert, Ed Copeland, and Danielle Angelari have been nominated as slate for the term of 10/1/2021 to 6/30/2022. I will take roll call for the vote. Mariana Body, yes. Dick Kunert,
Yes.
Dr. Copeland, Danielle Angelari.
Yes.
Dr. Bill Gorski,
Yes,
Dr. Terry Giardini,
Yes.
Tim Neighbors,
Yes.
and Linda Sandquist.
Yes.
Okay, we have made that. We've made it through that action item, and thank you all. Moving down to our discussion items,
Wait, Marianne,
why-
can I just say something before we go on?
certainly.
No, this is going to go till June, so we're going to do this again in June.
Mhm.
Okay. Did I miss something along the way? I thought when we first did this, we said we were going to do it for at least 2 years to 4 years. So that way we don't, there's some continuity and we're not always changing it up. Did I miss something?
Well, I think we'd have to change our bylaws. Am I correct about that, Jason? In terms,
What changed was the passing of the Senate Bill 2278, which now dictates that the Mental Health Board operate as a community mental health board according to the Community Mental Health Act. And the Community Mental Health Act dictates that the election of officers be, that the terms of officers be from July through the end of June. So while it was, before the passing of that legislation, the board created their own customized term for officers. Starting when that goes effective, July 1st of next year, it would be, I guess, the appropriate time to align it with the Community Mental Health Act's terms. So that was the reason for this being a shortened term, but then the terms thereafter will go back to being for 1 full year.
Jason,
Yeah, I
does
guess
that
I
mean
missed
that our bylaws are not in sequence with the Community Mental Health Act?
Correct, the bylaws should be updated.
Okay,
And we can add that to the agenda for next
okay,
meeting to update that
all
appropriately.
right. Okay,
Well, and Jason, my thought would be that we should consult with our attorney and yourself so that we can streamline the process a little bit. Does that make sense?
To seek the attorney's advice on the updating of the bylaws?
Just to make sure that it's consistent with the changes in the Community Mental Health Act.
Sure.
Yeah. Okay.
And it would be nice to know if there's other areas that need to be adapted, edited, or adjusted as well.
Correct. Okay, moving on. The first discussion item is FY 21-22 funded program updates. And in your packet, Jason and his team put together some really, I just think, eye-opening information for us. And thank your staff, Jason, and yourself. This was really enlightening and helpful for us to focus on as we go forward. But I'm gonna let you do the updating on this.
Yeah, well, please look forward to a more detailed presentation when we actually get our first quarter of outcomes, which will be due in September for the first quarter of programming, June through August. But we at least wanted to start thinking about, as we're heading into the planning updates, strategic plan updates, and we've talked about doing a systems coordination plan. What are some of those things we need to be thinking about for the next year of funding? And so we started to analyze, as we recently completed the outcomes templates for each of the funded organizations that they're required to fill out on a quarterly basis, started to analyze just without even getting the results yet, just the types of outcomes that they were reporting on. And what we identified was really just a couple of trends here. Number one was that while the community support system framework had focus areas kind of categorized as mental health treatment, crisis response, case management, and family and community services were together. In the outcomes, we saw that case management was more strongly associated with mental health treatment and really wasn't incorporated in some of the other types of programming, as well as it was integrated with the mental health treatment components. And kind of somewhat similarly, the community education part of it was strongly integrated with almost all type of programming in terms of educating the community about programming and mental health, but family services were much less present in some of those intended outcomes. So that might be something to, I think, maybe point out and highlight in the next year of funding as something that we might look to see more family services integrated in the types of programming that's being offered, and for more case management, which in the community support system model is really kind of that middle hub, which is so integral to making sure people can navigate the system and connect to all components, to really make sure it's highlighted that be more integrated with all types of programming and not just clinical treatment programming. So that was one type of finding. The other was taking a look at the target populations and how those numbers served proportionately reflect the community makeup. And it was actually pretty proportional overall. You'll see, for example, that children's mental health, which was reflected by the severe emotional disturbance, was, in terms of the target numbers, made up 17% of the total overall aggregate targets. And as a percentage of the population, for Winnebago County, children aged 5 to 18 make up 17.7% of the population. So that was almost directly proportional. Adults were pretty proportional as well. You can't get a perfect breakdown because the substance use category actually spans children and adults. The one area that we saw that was not proportional was infant and early childhood mental health, where the overall target numbers made up less than 1% of the total targets, whereas in terms of a proportion of the Winnebago County population, children 0 to 5 actually account for 7.2% of the population. So where research actually demonstrates somewhat equal types of risks or disturbance at each of these age brackets, we saw that the infant and early childhood population was underrepresented in the programming that was funded. So that might be another area to really highlight going into the next funding cycle as a key area for more programming.
And Jason, one comment in looking over all of this data that I think is significant. You mentioned that the family services really lacked in having that case management component, but the most, what struck me is also the crisis intervention, crisis services. And to me, there's nothing more important in terms of following up on people, that were in crisis, not only handling it, but ensuring that they have that follow-up with case management. So I think this is really important information that we're looking at today. So again, thank you.
So we, I think in terms of some next steps, as we start to actually get the first quarter reports from organizations, of course, we'll summarize all of that. But also, I think a good next step would be to compare what some of those outcomes are to the environmental scan gaps that were identified at the very outset of this, and going into our next year of funding to really recognize if there are some of those gaps remaining that we're really not hitting with the programming that was funded in the first year, to be more intentional about communicate what type of additional programming will be needed to fill those gaps.
Yeah, if I could just, by the way, I agree with Mary Ann, Jason. This is sort of elegant. I love the color streaming division of resources going to the various 4 categories. It's really well done and very easy to see. So the cascade is mental health treatment, crisis response, case management, and family and community services. And I guess what struck me, kind of trailing on your last comment, is maybe that's not necessarily inappropriate in the first year, given whatever the gaps have been and wherever the emphasis needed to be. Maybe it is, but to me, the usefulness of this is to reevaluate there's a resource prioritization here that we all would maybe say, well, yeah, that was appropriate. Or we'd say, well, no, it seems out of skew with where the greatest need and gaps were. And I don't know the answer to that, but to me, it's giving us what happened as a result of the awards relative to where the dollars are flowing. And it seems very appropriate to analyze whether at the end of the day, that was the appropriate prioritization.
I think those are really well-made points. I agree with you, Bill. And I don't have the answer offhand.
No, I certainly don't. I mean, again, maybe it's appropriate, but maybe it's, if you look at family and community services, there's much more that needs to happen there. And maybe the timing of it is delayed due to other priorities. But yeah, I think this is really valuable, Jason.
Absolutely.
Well, the other question I would ask to think about is my own observation is maybe this is I don't know how to put it, an identification problem in the 0 to 3 or 0 to 5 age range, that this, I'm not sure that the systems exist right now for identifying needy families or needy individuals. And I'm just wondering how other communities have handled that identification and provision of service. Just something to think about as we're going into the next funding year. Because I feel like there's a resource gap there that might have an implication in the numbers that we're seeing. Just that.
Wendy, I'm gonna, I guess I just want to point out, you know, the school district did the Ready to Learn project with Alignment Rockford, and that should have mapped all of that. There is a resource available that shows the kindergarten preparedness, and we could look at that and go backward to see all of that information. So,
Right. And there's a great map already.
right.
Good-
So
good
I guess
point.
I'm just pointing out that I would feel like that resource was there, and perhaps
No,
nobody
but-
has looked at it.
Well,
I mean, the
I guess
providers
my
have
point
not
is-
looked at it.
Jason mentioned early on,
I think that's where it's like our service provider. Say again, Dick?
well, Jason mentioned early on that, I mean, one of the needs that we have going forward is community education. And I really think that offers an opportunity to tie some of the things that, like Linda's mentioning, and for them to look. I would love to see, for example, the library take on a project because of their ability to be in all places within the county, and they also have the means, the technology of sharing, and I think they could be a really good glue for all various parts of what it is that we need to bring together to make the community
And
what's available.
Through alignment, the library had already volunteered, but that was pre-COVID shutting them down.
Yeah.
So,
Yeah.
yeah, but you're right, Linda, that stuff is out there and there are resources, but somehow we have to get people to be more innovative in offering services and also education.
I think, so like the Ready to Learn mapping process, which I was part of, really identified the needs for the 0 to 5 children and where they lived, and it kind of mapped it geographically. And I think maybe what Wendy's talking about that might be lacking still is kind of more of a systems map to understand what are the systems where children 0 to 5 are engaged, because they're not engaged always in the same systems that children 5 to 18 are, because those systems aren't all integrated with one another. And school starts at, for some, 3 with early education, but also for some it starts at 5, and in some cases mental health services, just because of the diagnostic criteria that are created, are not always appropriate until age 4 or 5 or 6. So I don't know that, and maybe it's worth a conversation to find out if others have done some systems mapping as it relates to that population. But you have to engage people in the systems that they're in, that they're working with, that they're engaged with.
What about the Erickson group that did
That's part of alignment. That's part of the Ready to Learn
one that got them here?
Right. But I guess I'm just thinking out loud now. Maybe this is part of the family services, children, and so that we're doing a better job of luring in family service providers and inducing them to look outside their normal box, so to speak, to the infants that are in a family. not just let's say school age kids or preschool age kids who already have a problem. Just something for us to think about.
And so if I could just highlight, because I don't want to leave out those that have done some of this work, but Crusader Community Health did include 0 to 5 in theirs and targeted early childhood and infant mental health. So, and the doula program. So there might be some good learning that can happen from the first year programs, even though the target numbers were much lower than some of the other age brackets, at least to learn. Engaging through a primary care system, for example, is a place where we would expect that families and their young children would be engaged in that service.
That's a very good point, Jason. Any other discussion, comments on this topic? Hearing none, I will move on to the next discussion item, and that involves a legislation update. And Jason was thorough enough to go through and pick out bills that the governor signed that'll benefit mental health for sure.
So this legislative update is coming from ACMI, with whom we are a member organization, and I had the opportunity to sit in on their business meetings last week or 2 weeks ago, and heard from their legislative committee some of the updates and some of the highlights, and it was really interesting. They've kind of noted, if not, I don't know if it's totally factual or anecdotal, that it seems like there was a lot of mental health legislation passed in this last legislative cycle, and certainly I think the impacts of COVID and how much awareness that has brought to mental health on a national, maybe even global level, probably has influenced that to some degree. And certainly on the forefront of a lot of people's minds. In terms of some specific legislation, I'd like to highlight the Public Act 102-0016, which is an amendment to the Children's Mental Health Act of 2003, will now require a children's mental health plan, I believe at a state level, that will include recommendations for ensuring that all Illinois youth receive mental health education and mental health care in a school setting. So certainly that could have a pretty significant impact.
Absolutely.
Public Act 102-0337 is an amendment to the Mental Health and Developmental Disabilities Administrative Act that will require the Department of Human Services to create an online database and resource page on its website that specifically will highlight resources as it relates to crisis response and first responders. So I think that will be an interesting thing to keep an eye on as we've kind of talked about what type of resource guides are needed locally to see what the state provides as an example. Public Act 102-0066, which creates the Housing is Recovery Pilot Program Act. And this looks like a very interesting, innovative program that will provide bridge rental subsidies for individuals at risk of unnecessary institutionalization or at risk, high risk of overdose. So it looks like some type of housing vouchers or something likely flowing through the state, hopefully to local areas. Worth keeping an eye on, definitely, to communicate to our local agencies. One that probably hits really close to home for the type of programming that we funded this year is this House Bill 2784, which creates the Community Emergencies Services and Support Act. When this report came out, it had not yet been signed by the governor, but it has since been signed by the governor. So it essentially provides that each 911 call center and provider of emergency services dispatched through 911 system must coordinate with both mobile mental health and behavioral health services. And I believe also dictates the creation of a 988 crisis line that is not the same as 911, but certainly should likely be coordinated with 911 in terms of making the appropriate dispatch, so that irrespective if somebody's calling 911 or they're calling 988, that they receive the appropriate level of response from either a mental health clinician, a mobile response with a paramedic and a mental health clinician, or a co-responder response with a law enforcement officer and a mental health clinician. And I believe that what I heard from the legislative committee was that there's going to be some additional planning done on both a state level and a regional level to develop regional task force for that. And the goal is that there's full implementation or full compliance by January 1st of 2023. So they're expecting that there's going to be some lag time for getting all of the local areas up to speed on that. Tim, I think you were going to ask a question. You're muted.
I was going to ask, how will this affect or compare with the 2-on-1 system that we have established, or that the United Way have?
I'm not sure who's going to be required to operate the 988 number and what, if any, integration it will have with 211, but I think it's a great question, and I think the more we can be part of the conversation, you know, at a regional level, certainly at the very least, I think it would be good to highlight some of those questions and seek further integration beyond just 988 and 911.
Go ahead.
I was going to say there's like a public stakeholder meeting for the 988 integration every month for the public to join in. The next one is on September 28th. It's all via Zoom, so it might be something interesting for you all to watch.
What was that date?
September 28th. And I think it starts at 1.
So my question is that reading the legislation, the 988 number seems to be reserved for people calling for help because of mental health, whereas the 211, in my understanding, they can call for just a broader spectrum of concern and resources. Am I right about that? I thought that the 988 was going to be more dedicated to the mental health.
Pretty sure 988 directs you to the suicide prevention hotline, but they're trying to figure out a way to integrate that with 911 dispatch as well.
Yeah, I can see the 911. Okay.
I think this seems like just a great idea and a great direction. I'm wondering, where are we at with the education of our operators, our responders, when they get calls, to be able to distinguish and then triage appropriately? It seems like we have talked about that. I can't recollect if there are initiatives out there to do so, but that seems to be a pretty important piece of this.
Well, I think that is still in flux. You know, they had requested in their initial proposal funding for specialized software, you know, for the 911 center. And that is something that we did not fund as a part of their total proposal. However, while they were, you know, while we were having dialogue with them around this issue, they, if you recall, it was advertised that they trained the 911 operators on domestic violence and strangulation so that they would know exactly how to handle that population. So, you know, in a sense, they still have the burden, if you want to say it's a burden, but to me, it's just granting important knowledge to the operators to handle mental health, suicidal, substance abuse kind of calls. But I don't at this point, and anyone can correct me if they know differently, that there is specific training going on or has gone on in the last year or so for the 911 dispatchers. So, yeah, I mean, it's not solved yet, put it that way. But this, what this new legislation does, in my estimation, it's going to be taking the burden off of the mental health board, you know, as a special request, because the state kind of supersedes. It's a law now that they have to have a specialized number by 2023 for the mental health. So that'll certainly help the programming that we funded, for sure. And Jason, the other update that I was hoping you just kind of visit again is the SB 2278 legislation, because just to clarify for our board that this is signed and done.
Yeah, so that is actually now Public Act 102-0379 that was signed by the governor into law. And I'll just read the final language on that, any county that issues one of these imposes a special county retailer's occupation tax shall establish a 7-member mental health board, which shall have the same powers and duties and be constituted in the same manner as a community mental health board established under the Community Mental Health Act. And it provides that monies from the special county retailers' occupation tax that are earmarked for mental health or substance abuse purposes shall be deposited into a special county occupation tax fund for mental health and substance abuse, and that the 7-member mental health board shall administer the fund.
So it made us official. Okay. Any more discussion at this point? If not, we'll move on to other matters, and I have no agenda item for other matters. So the next and final is a motion for, Bill Gorski.
Marianne, I was just wondering where things were at with our additional board member conversations from, I think it was last month.
Correct.
Where that stood.
I'm going to let Jason fill you in on that, what he has done and what, you know, he sent to the chairman. Go ahead, Jason.
If Tim wants to give an update on that.
Oh, good.
I'm happy to offer any details, but it might be a better question for
Tim, have you heard anything?
I haven't. Maybe Jason has, but as far as not, I was just gonna say it's just up to the chairman who decides. He has our recommendations.
Right.
Other than that, he hasn't said anything else about it.
I will say I have an appointment to meet with him next week.
Oh,
But I initiated that.
Good for you.
That's good.
Well, I decided if this is going to happen, maybe there needs to be
right.
some urging. So,
And the letter went to the chairman when, Jason, has it been? Well, it's been since our last meeting.
Yeah, I sent it after the last meeting where it was approved, and Chairman Shirley did ask for the full packet of all of the applications that were received, and I sent that to him as well.
Oh, great. Great.
So we're just awaiting his response.
Great. Appreciate it.
Yeah, and hopefully we'll know soon.
Uh-huh.
Okay, so I do need the motion for adjournment.
So moved.
I second.
Okay, roll call for this as well. Mary Ann Abadi, aye. Dick Kunert,
Aye.
Dr. Copeland, Danielle Angelari,
Aye.
Dr. Gorski,
Aye.
Dr. Giardini,
Aye.
Tim Neighbors,
Yes.
and Linda Sanquist.
Yes.
Okay, well, thank you all very much, and we'll see you next month.
Thanks, everybody.
Good
Enjoy
job.
fall.
Yeah.